Thank you. Welcome back from the break, everybody. And my name is Andrea Burrows. I am with the Interior Center BC Support Unit based in Kamloops and the Secwepemc Nation. And I hope everyone had an opportunity to stretch and to check out the hallway chats. We will be moving right along. So I'll start with some housekeeping things. If we can keep our presentations to 15 minutes, including Q&A, and I'll be monitoring the chat room or the chat panel. So if you have comments or questions, I really encourage you to put them in the chat or wait. I'm sure that there'll be questions from the presenters, an opportunity to ask those questions. So it's always great to engage in dialogue. So without further ado, I'm going to hand it over to Sarah Park and Sarah Park and Vanessa Dizano for their presentation.
All right, can everyone see the presentation? Okay, perfect. Great. So hi, everyone. Welcome to our presentation. We're so excited to share our patient-oriented research project called Empower. So my name is Sarah, and I am a research assistant working with the Vancouver Stroke Program.
And my name is Vanessa, and I'm the study manager for the studies we'll be talking about today.
Perfect. So before we begin, I would like to acknowledge that we, the presenters, are gathered on the traditional, ancestral, and unceded territories of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam nations. I also acknowledge that many of you tuning in today may not be from those sites that I've listed, and I would highly encourage you to take the time to learn what land you yourself are living and learning on.
We would like to disclose Bayer has provided the study drug in kind for the clinical trial. Cerebral venous thrombosis, or CVT, is a rare cause of stroke that most commonly affects younger women. Prognosis is excellent when measured with typical outcome measures used in stroke trials, like the Modified Rankin Scale, or MRS. However, this does not account for residual symptoms that significantly impact quality of life, such as chronic fatigue, headaches, mood issues, and cognitive problems. We wanted to directly consult our patients, who are a young and high-functioning group, to address outcomes that are both meaningful and scientific for our clinical research. We are conducting two clinical studies, SECRET and Top Secret. SECRET is a Health Canada regulated multi-center clinical trial comparing rivaroxaban to, which is a direct oral anticoagulant, to standard of care for treatment of CVT. To date, we have enrolled over 50% of our target sample size. Alongside the clinical trial, we have a registry for those ineligible or who decline to participate in SECRET. This may include pregnant women or individuals who did not give consent for the trial.
So the purpose of Empower, which is the patient engagement side of the SECRET trial study, are five-pronged. So number one, it's to connect former patients, supporters, clinicians, and researchers to share information and develop research questions in a more collaborative way. Number two is to address the need for outcomes that are more refined than the typical functional independence. Number three is to learn more about a rare disease, which is so that more common patient-centered outcomes could make future trials easier to power. Number four is to create and engage patient networks that may facilitate engagement in future research. And finally, number five, to facilitate connections between survivors of a rare disease and their caregivers with each other to promote mentorship, peer support, and knowledge exchange. So overall, the mission statement of Empower is to engage, empower, and connect people with cerebral venous thrombosis and their loved ones. So now that you know about the higher level purpose and mission statement of Empower, let's get into the timeline. We started by creating the Patient Advisory Core, consisting of a diverse roster ranging from patient advocate to neurologists and even researchers to help co-create the CVT survivor questionnaire that would allow survivors to share reflections on the most important outcomes, as well as, of course, invite them to the forum where there were different kind of approaches and target goals. So whether that looked like opportunity to ask questions or connect or refine those meaningful outcomes and build awareness, and together to get feedback on the website and build that peer support and mentorship. So the core group that has been established did not only participate in helping with the planning and developing of the CVT forum, but they are also consulted for their expertise and experience to continuously improve the secret trial study in terms of feasibility and patient experience. So while we are still in the data collection phase of the trial, the advisory core will also be heavily involved at the end of the trial when we develop knowledge translation materials for CVT survivors and their supporters. So now we'll delve into each section in a little bit more detail.
The pre-form survey was completed by 23 respondents. 83% were female, with almost all experiencing residual symptoms. Most of the respondents were between the ages of 35 to 49, so that young cohort that we mentioned, and had their CVT diagnosis in the last 2 decades. Here you can find some major themes from the survey. Headache, anxiety, and fatigue were the top 3 symptoms experienced by CVT survivors after being diagnosed. About 90% of respondents experienced some sort of headache. Fatigue and anxiety affected quality of life to the greatest extent. Lack of knowledge about CVT by patients and non-stroke specialists were identified as topics of concern. Respondents identified exercise, socializing, healthy eating, and hobbies to improve their quality of life and symptom management post-diagnosis. Other activities respondents found for managing their symptoms included being more informed and accessing therapy like speech therapy, occupational therapy, and even acupuncture. Respondents had many questions about CVT, including the exact cause, prognosis, likelihood of reoccurrence, and measures they could do to prevent a future event. So here's a picture on the day of the event, which was January 19th of 2019, and it was held in Vancouver, BC, where former CVT patients and their loved ones were invited to attend. Here's a screenshot of the day's agenda. So you can see that results from the survey that I discussed inform topics of discussion, including the CVT journey, knowns and unknowns, wellness, and online resources. Here's a picture of Sarah, a computational biologist and CVT survivor who shared her story and patient journey with attendees. This created a space where patients could share their own unique journey with CVT. Similar sentiments of uncertainty were shared by others and the need to revise expectations of their new normal. This is Sohaila, who was a neurology resident with us. She led the wellness session to discuss pharmacological and non-pharmacological strategies, which included a mindfulness meditation exercise. We also invited a graphic recorder to produce illustrations of the sessions to maintain engagement throughout the day. These graphic recordings will also be used as a knowledge translation tool to add to the website. Our CVT website here is being developed as a resource to the public for patients, caregivers, and clinicians wanting to learn more about the disease. Through the website, they can connect with each other and find out how to participate in research.
Great, so with 28 attendees, with 7 patients and 4 caregivers from BC at that forum, the main topics/themes covered include sharing similar experiences of uncertainty after diagnosis, having to redefine that normalcy, and revising expectations of achieving pre-diagnosis life, identifying patient-centered outcomes to bridge the existing knowledge gaps in CVT, recognizing that resources for patients, caregivers, and non-neurologists were lacking, and lastly, sharing helpful non-pharmacological therapies to manage the symptoms of CVT. So after the forum, we also asked for feedback and we found some common themes for successes, including having that diverse perspective of researchers, patients, clinicians, graphic recording, and the interactive nature of the day, such as having Q&As and topics that really shaped to their needs and questions. With regards to areas of improvement, one example that was frequently mentioned included having more note takers in general. So for example, having a note taker for each table discussion rather than just one per session, and having more check-ins with the graphic recorder in our specific situation to show progress in the discussion and maintaining that engagement. So from this experience, we found the following to be valuable lessons for patient engagement. So number one, having some sort of visual to reinforce discussions and having lots of it. So having a note taker for each discussion table as previously mentioned. Number two, creating that space to share insights from different perspectives, specifically in small group sizes to elicit better discussions with researchers, clinicians, and patients intermingled throughout. Third, to keep it interactive. So whether that looks like frequent breaks, breakout rooms for virtual discussions, having a Q&A, or keeping the day short to make it bite-sized and accessible. And lastly, to set the stage for the event early. So that could look like having a guest speaker to open the event, reinforcing the idea of meaningful participation by continuously acknowledging and emphasizing that voices are being heard, or even starting off with community guidelines.
So as next steps and milestones, we hope to finalize the website very shortly to make it available to the public. Further, we would like to invite forum attendees back for interviews and explore potential long-term impacts of forum participation. So have they stayed in touch with any of the other attendees? Have they been involved in any research? Have they accessed any resources they wouldn't have otherwise? And finally, we'd like to apply what we've learned to future patient engagement initiatives, for example, getting consent proactively. As a conclusion, we wanted to share 2 publications from our group on patient-centered outcomes in clinical research, should you like to learn more.
Perfect. Thank you so much, and enjoy the rest of this breakout room.
We have a couple more minutes for questions. So I do notice that a question was answered in the chat box around the usual care for CVT patients and who cares for them, neurologists. So thank you for the answer there. Neurologists or hematologists usually, however, they often present to the emerge where they go undiagnosed. And then I asked about paramedics being involved in the care before they arrive to the emergency department. And so they can sometimes not be diagnosed initially due to its rarity and its presentation. So thank you for that, Thalia.
Yeah, sorry to interrupt you there. It's Thalia Field, just sneaking onto Vanessa's registration there. Missed the paramedic question. So just a qualification about people not being diagnosed in the ER. They're sometimes not initially diagnosed, but that's not a unifying answer. You know, where paramedics have to transport the patient to the hospital, then they may be involved in care. If someone, say, presents with a seizure or is in a lot of pain and needs to call 911 prior to presenting to the emergency room. But sometimes because symptoms can present with just headache or visual blurring and they come on gradually, unlike other types of stroke, sometimes people will present to their family physician's office or another context instead of the emergency room to begin with.
Okay, thank you for that clarification and more context. Thank you. So how did the POR, patient-oriented research activities, help to inform the ongoing clinical trial?
So I think I could take a stab at this one first. So I also manage Secret trial, which is the clinical trial portion. And I think understanding some of the barriers to participation have been really informative in terms of optimizing recruitment. So I think given the cohort with this disease, that they're usually younger, high functioning, they have other priorities like returning back to work or families, kind of identifying what those barriers are so that we can provide childcare if need be, or working around doing follow-ups after office hours if they work during the day. So I think we've tried to use that information to optimize our recruitment strategy. Thalia, I don't know if you have anything to add.
No, I think just getting feedback initially about how the battery was going, any addendums we make to informed consent, patient level summary for just to put with the informed consent and other kind of larger materials, answering any patient concerns about kind of modifying the assessments as time goes on, have all been really very valuable contributions from our group.
Good, good, thank you. Okay, we're going to move on to our next presentation. Lanzi Hung, please take it away.
Thank you, Andrea. Can everyone see the slides? Okay. So hi everyone, my name is Lanzi, and I'm a student research assistant with Fraser Health under Dr. Sall's supervision. So I'm here today presenting your study on behalf of our research team. So the topic of my presentation is working with research patient partners in conducting MRI study on myalgic encephalomyelitis, selection and setup of the functional MRI task. Sorry, my PowerPoint just froze. Okay. So first off, let me introduce you to our multi-center research team. So we have Dr. Nicole and his team from BC Women's Hospital, who will mainly focus on the recruitment of our patient participants, and our patient partners, Katie and Hillary, who have been actively engaged in all aspects while providing their perspective throughout. And finally, Dr. Sall, who will be leading the Fraser Health team in conducting the MRI experiments. So here will be the plan of my presentation. I'll first be talking about what is ME, what are its symptoms, and introducing to you our project, then presenting you the functional task that the team has chosen. So myalgic encephalomyelitis, also survey. So ME typically evolves into a long-term disabling condition, and estimate that 25% of patients are housebound, meaning they're rarely able to leave the house. And ME is a multi-system disease that can affect the central nervous system, autonomic nervous system, endocrine, immune, gastrointestinal, and the musculoskeletal system. We can see that this is a very highly complex illness. Now you might wonder what causes ME. So although the underlying molecular basis is still unknown, one of the proposed mechanisms is that ME is triggered by viral infection, such as Epstein-Barr virus or the flu. With our current pandemic situation, a relevant question to ask is, will there be COVID-19 patients possibly developing ME? It's already been observed that some COVID patients continue to feel sick after longer periods of time. Here are some typical symptoms patients will experience. So in the box on the left-hand side is the case definition from the Institute of Medicine, meaning patients need to have these symptoms before diagnosis using the I criteria. They cannot perform activities they were previously including trivial physical or mental activities. They'll experience post-exertional malaise, a hallmark of ME, which is the worsening of symptoms after activities. In addition to unrefreshing sleep, orthostatic intolerance, and cognitive impairment. And here on the right are some other symptoms a patient can experience. However, each patient can have a different representation, making the disease very heterogeneous. As we have seen on the previous slide, diagnosis is based on a criteria of symptoms, which means patient can struggle a long time before diagnosis, and after there's no cure, no FDA or Health Canada approved treatments. Patients learn what their body can handle through trial and error, and often just managing their symptoms by pacing or not overexerting themselves. The lack of objective biomarker treatment and the potential significant effect on the quality of life on these patients highlights the need of more research in the field. And recent MRI study results have suggested a promising way to better understand ME. This is by looking at the brain inflammatory responses in these patients, which led to the development of this current study I'm introducing you to, a multimodal MRI study targeting the neuroinflammatory response in brains of patients with myalgic encephalomyelitis, chronic fatigue syndrome. This project was initiated by our patient partner who approached Dr. Song expressing the need of research for ME and subsequently built the research team. Since then, the team collaborated, working side by side from grant application, project design, and ethics application approval. So in this project, we aim to directly reveal brain metabolic and functional changes underlying neuroinflammation. And the three objectives of the projects are how to investigate the feasibility and reliability to study neuroinflammation in these patients using MRI, how to effectively characterize the potential neuroinflammation using fMRI and MRS, and do the signs of neuroinflammation differ between controls and patients? If so, whether they're related to clinical expression. So to achieve these, 20 female ME patients and 5 matched controls will be recruited. They'll be scanned using multiple MRI modalities, which I'll talk about next. And there'll also be a patient panel discussion with 7 ME patients. So our patient partners will be leading the panel discussion and the recruitment process. So the 3 types of MRI scans we'll be doing are anatomical scans, magnetic resonance spectroscopy imaging, which is used to measure brain metabolite and brain temperature. There will be 2 sessions of MRSI, which is separated by the functional magnetic resonance imaging. This is used to detect brain functional activation. And during this session, the participants would need to perform a fMRI task targeting attention and working memory. And the objectives of the task is to test the differences in attention and working memory between the patient and control groups, and evoking brain activation for metabolic comparison pre and post task. And the task the team have chosen is called the MBAC task. But during the MBAC task, participants will be shown a series of letters one by one, as shown here. They'll be asked to remember these letters and decide whether the letter they're seeing right now is the same as the one they have seen previously, and they will need to answer every time they see a letter. And we can take a look at this diagram as an example. So for the one back task, participants will need to decide if the letter they're seeing right now, it's the same as the one they have just seen. So the R and the R in this example. And for the 2 back task, they will need to decide if the letter they're seeing right now, it's the same as the one they have seen 2 letters ago, the M and the M in the red box here. So this task was chosen for several reasons. First, it is a well-developed task in the fMRI field with already established difficulty levels, easier for researchers to manipulate. And its instructions will be easy for the participants to understand. We have also found papers study ME using this task, meaning it is doable for a particular patient population. This task was presented to our patient partners for discussion, and after discussion and considering the fatiguing syndrome of our participants, the team have chosen 2 designs to implement and test amongst us. So the first design is to have a 5-minute task where the participants will start with a short rest session along with a short introduction, which will tell them which difficulty level they will be doing next. And in this example, block 1 will be a 1-back task for 25 seconds, and they'll have another rest session and followed by a 2-back task, and so on. And the block order will be counterbalanced, meaning half the participants will be doing 1 back, 2 back, 1 back, 2 back, so on, and the other half of participants will be doing 2 back, 1 back. If this design will be too difficult, we'll be using a 4-minute task design, which only contains 1 condition, the 1-back task. This will contain a total of 6 blocks, and each block will also last 25 seconds. So this example of what the participants will see in the MRI machine doing the 2-back task. So they'll first see a letter A, which is the stimulus, and they will need to answer non-match because there was no letter seen previously, and they'll see interstimulus, followed by a C, and also need to answer non-match because there was no letter seen 2 letters ago, and so on, until when they get to see the second letter C and need to answer match because there was another C seen 2 trials ago. So for both block designs, each block will contain 12 letters stimuli, and 33% of the stimuli will be targets, and the stimulus and interstimulus will both be displayed for 1 second. Currently, we're using presentation to implement the task for testing, and we're using the experimental package provided by presentation based on and making modifications. When finished, we'll be having our patient partners to try for feedback, and based on their input, the team will choose the most appropriate task difficulty level without challenging our participants, and along the way, we'll have continued optimizations. And here we're highlighting the works that our patient partners have done throughout. It is expected that this project will confirm neuroinflammation in ME patients and potentially lead to future research on diagnostic biomarkers and treatment for ME, all to improve ME patient experience and care. Our patient partners will continue to stay involved and support by leading a patient panel discussion, testing our fMRI task, and share results with the ME patient community. Thank you for listening. I welcome any questions.
Great, thank you. Do we have any questions? In the chat box, or you can unmute and ask it to yourself. Okay. So I did notice that we'll go to 3:15. So if more questions kind of come up, we've got a few extra minutes before the final panel discussion at 3:30. People may want to jump off to another 3:15 to 3:30 discussion, or they can stick around and we can answer more questions. So there's always that option. There's a question here. Can this test account for ME folks who have not had the disease for decades?
Who have had the disease? Okay.
Who have had the disease for decades? Sorry.
Okay. For our inclusion criteria, we are only including participants who have had symptoms for less than 5 years. So for the MRI part of the study, we're not enrolling patients with disease over the decades, but for the patient panel part, we are recruiting.
Good question. Okay, All right, so we'll move on to our next presenters. We have Diana Solo and Claire Milden-Berger. I'll unmute Claire. Oops. Sorry, Claire, you might have.
I think I got it.
There, you got it. Good. Take it away.
Hi, everybody. Thank you so much for joining us. My name is Donna Solomon. I am a knowledge translation specialist at the Birthplace Lab at the University of British Columbia. I also own my own business offering a range of KT-related services. Claire, would you like to introduce yourself?
Sure, I'm Claire. I was participating in this project both as a sort of have my patient expertise and also working with the Birthplace Lab. And I'm also currently a midwifery student.
So for our backgrounds, just to let you know, we were doing knowledge translation for the Changing Childbirth in British Columbia study, which was a participatory study that involved clinicians and clinicians, patient partners, NGOs, etc. Claire and I are not clinicians, or Claire is studying to become one, but is not yet one. I am a social scientist and a theatre specialist, a theatre artist. So both of us have far more experience on the patient side of the equation when it comes to medicine. So when we're talking about using theatre for knowledge translation, there's a lot of different ways you can approach this. I particularly like ideologically challenging entertainment. It's adapted from a conflict-centered approach into the healthcare setting. So at its core, ICE uses absorbing, entertaining narratives to communicate and engage audiences on complex and often controversial topics. I'm not going to go into all the details and theoretical foundations for how ICE works, but I'm going to highlight a few elements of what a good ICE production looks like. The first is that it's entertaining. Now, this doesn't mean it has to be superficial or funny. It means that it should be absorbing, it should be engaging, and should allow audiences to connect to the stories being presented on the stage. It's the key element that makes ICE effective. The other thing I'd like to talk about is engaging the moral imagination. So the moral imagination is usually talked about in a conflict setting. And in that context, it talks about imagining ourselves in an interdependent web of relationships that includes our enemies. Now, in a healthcare setting, talking about enemies is probably a little strong, but in the relationships matter. So when we talk about relationships in healthcare, talking about an interdependent web of relationships between caregivers, patients, policymakers, and researchers makes complete sense. And that's what I talk about when I talk about the moral imagination in this context. ICE also requires engaging multiple perspectives. It's not typically polemical, so these productions really strive to represent as many viewpoints as possible, even and sometimes especially when they contradict one another. Which then leads me to the final point that I'd really like to highlight, which is complexity, and really just embrace it. It's part of the process. So if you want to learn more about ICE, I will engage in 1 second of shameless self-promotion and recommend you have a look at my book, which is Ideological Battlegrounds. But like I say, that'll talk more about what ICE is, the theoretical foundations, and some evidence of its efficacy. So like I said, the study that we've been doing knowledge translation for was called Changing Childbirth in BC. CC and BC use both conventional and community-based participatory research methods to study experiences and outcomes of maternity care in British Columbia. Now, over 2,300 people completed the survey and over 130 people participated in one of 20 focus groups. We examined a whole range of issues about care during pregnancy, differences between care providers, place of birth, access to care, levels of autonomy, and respectful care. I'm not going to go into all the details, but I'll go through a couple of interesting outcomes from the study. The first is that of the women who received C-sections, or inductions, there was a significant percentage of those that felt pressured into those interventions from their care providers. There were also significant differences in the levels of respectful care or autonomy reported by women or by families, depending on the different kinds of care providers between midwives, family doctors, and obstetricians. Not surprisingly, vulnerable groups reported significantly lower levels of respectful care and autonomy. So when we talk about vulnerable groups in this case, we talk about people of color and people with medical and social risk factors or pregnancy complications. So when we were going to do the knowledge translation, we wanted to create a theatrical production that would reconnect the community that provided the data with the outcomes of the studies and with our plans for going forward. We also wanted to re-engage them in the process of determining the future of how we were going to translate knowledge into practice. And so for that, we really started with the Changing Childbirth in BC focus groups. And I think, Claire, you can talk about how you started there.
Sure. So I was going through the focus group material to try to find stories to be used in the production, and it was complicated. There's a lot of material. Some material from the surveys were appropriate, but a lot of it was from the focus groups. I was trying to balance sort of good stories and bad stories, to balance different care providers, and balancing demographics. There was an attempt to do it, but it was often not clear actually who exactly was speaking. And some of it had to be inferred based on, say, a focus group held in a rural area. We would assume they were rural, but we didn't have a lot of information about their demographics. We were trying to match quotes with the actual findings of the research. So if some finding was very strong, we tried to find a quote or a story that would exemplify that finding. And also, importantly, like Donna said, for the actual theater part, there had to be some narrative to it. It had to be an interesting, engaging story with, some character to it. Yeah.
Thanks. So when Claire identified these stories and pulled them for me and cleaned out, the ers and the ums in the text, I then took those stories and did some further analysis, looking for common themes, looking for how they related to the data that we had. And I'll just pause here and let you know that what you're seeing on the screen are direct quotes that were used in the production that came from the study data. And so from this thematic analysis, I then took it to the next step, which was to start to select stories that would be included in a play. And like Claire said, we really wanted the stories to be representative of the data. We wanted to make sure that we had both positive and negative stories from all different caregivers, including midwives, family doctors, obstetricians, and nurses. At the same time, we also wanted to make sure to include a few outliers, people that had atypical experiences and experiences that should never have happened. I then found one story that included what I would consider a narrative through line, something that could anchor the script and create a story that we could then follow all the way through the entire play. I used that through line to build the script and use the additional stories that were being told by other people to create a 20-minute play around it. All through this process, I kept returning to the requirements to be representative and to be honest about what we were saying and how it related to the data. I need to emphasize that in the creation of this 20-minute play, every single line of the play was said word for word by a participant in a focus group or in the surveys. I added the occasional transitional phrase to connect the stories, but beyond that, the entire text was taken directly from the transcripts. So now we get into the more traditional theatre side of things. We put out a casting call, we emphasized the desire to find people with different ethnicities, body types, accents, etc. We were actively seeking a diverse cast. In the end, you choose from the people who audition, and we came up with a fantastic cast of 5 amazing actresses. Rehearsals are much like they are for any other play. You work through the text, you work through meaning, interpretations, but at the same time, there are a few differences. The first is that because the stories were told by real people, the cast felt a very significant responsibility towards those people, and they were very conscious of the importance of honoring those experiences. An ICE production also requires a lot more education than traditional plays. So while this is very standard in ICE, it's not standard in traditional theatre. So in this case, we did have a nurse on the cast. We also had a new mom on the cast, but beyond that, nobody had much experience with having children or with reproduction. So we had a couple of rehearsals where the clinicians from the birthplace lab came in to answer questions and provide clinical information. And then we had Claire, who became sort of our technical consultant. And maybe you can talk a little bit more about that, Claire.
Sure. It was really interesting coming from a more academic background to have this kind of expertise really valued. It just, this kind of personal experience, and it just made me think about how much you hold on to and how much you take away from lived experience, and you actually do know a lot, and you kind of probably take for granted what you've experienced and what you've felt. And so it just highlighted to me kind of the power in these experiences, and I could see it when people were watching it and could relate to it, how powerful that was. So that was, yeah, it was really interesting to be a part of that the whole way through.
And Claire was amazing. So you'll see the three women on stage. Neither one of them has ever had a child. The pregnancy bump on the woman in the middle is completely fake. Claire made that. And she was teaching the women how to hold babies, how to make it look real when you're pretending to breastfeed, and so on. She was extraordinarily useful as a technical consultant and as a lived experience resource in the room. So we had 3 performances in late February and early March in Vancouver and Burnaby. And each event started with the play, 20 minutes, and then it was followed by about an hour of discussion, which included suggestions, discussions, snacks, conversation, feedback on the play, everything we wanted. But we really wanted people to share their views for future KT and what we could do to improve practice moving forward. We got amazing feedback all the way through. And I can't go through all of it because it was extensive, but we had numerous requests to share the production more broadly, to create similar performances, make it a full-length play, a video, a documentary. In other words, incredibly strong feedback about the efficacy and power of the production. One example was a caregiver who specializes in working with people with traumatic experiences in medicine, and they were stunned at how moving they found the production, even though they live these experiences on a daily basis. They still found this performance, these stories, incredibly emotionally and intellectually evocative. We also obviously got a lot of feedback related to the content of the study and the stories, including the desire for change at community, caregiver, and policy levels to make patient and family-centered care a reality. And the power of this type of knowledge translation is that it can engage people emotionally and intellectually on issues that are complex, nuanced, and controversial. It amplifies the patient voices right alongside those of researchers and practitioners, and does so in a way that honors the individual perspectives and the experiences of those who participated. So with that, I will say thank you, and I hope I can answer some questions.
Great, thank you, ladies. Excellent presentation. What an inspiring and different way of presenting KT. So big congratulations, and I can just imagine the feedback and discussions. How it would just be so inspiring. It'd be lovely. Anyways, sorry. So we have a minute left, and I'll open it up to questions. Don't be shy. Okay, thank you again, everybody, for joining us today. And for our presenters, a huge, big thank you for your time and effort to be here, and for all of the incredible work you've been doing. So I will let it go because there may be other sessions that people want to join in on. And we'll reconvene back at the main session for one of our final sessions at 3:30. So otherwise we have a 15-minute stretch. So thank you so much. Take care.
Thank you.